Good afternoon, everybody. I would like to thank Sharma sir for giving me this opportunity to be part of his very popular IC. I would be presenting on infra-oblique surgeries. So the presentation would essentially contain basically the indications of infra-oblique surgery. Infra-oblique is basically a very forgiving muscle, and infra-oblique normally, most of the surgeries related to infra-oblique would be recession and weakening of infra-oblique. F5. Okay, so so the indications are obviously, there are multiple indications for this. You can have a primary infra-oblique overaction. You could have bilateral essential overactions with V pattern with horizontal strabismus, unilateral essential overactions combined with horizontal deviation and a significant hyperdeviation in primary position. One can have a dissociated vertical deviation with infra-oblique overaction. Multiple indications, basically whenever there is an overaction, you can tackle infra-oblique. And so these are few contraindications when there are apparent overactions, and also apparent overactions in Duane syndrome when there is no true overaction of infra-oblique. We should not go for infra-oblique surgery. So basic anatomy we should be knowing whenever we are dealing with infra-oblique muscle. This is the only extraocular muscle. We know that it is the only extraocular muscle which starts near the front of the orbit. It has got the shortest course, shortest tendon to almost nil tendon. Vortex veins are reality, and they are very close to the insertion, and also the insertion is very close to the macula, and it does not contribute to the blood supply of anterior segment. So you can very well do it along with two rectus muscles surgery. And surgical anatomy is again important to understand the multiple, there is a load number of ways you can weaken infra-oblique. There are multiple people, legendary people who have described infra-oblique underaction or infra-oblique recessions in their name. So from origin it is inclined posterolaterally. It has got a large wide insertion. Anterior 10 millimeter posterior to the infra edge of lateral rectus insertion. This is very important when when you are looking for infra-oblique. It is quite easy to detect infra-oblique. You just have to hold the lateral rectus and then go at least 10 millimeter posterior, and the anterior edge of infra-oblique is posterior to the inferior edge of lateral rectus insertion. So it is posteriorly, it is up to 5 millimeter from the optic nerve, very close to optic nerve, and the maximum length available for recession is 12 millimeters. And basically this is limited by the lateral margin of inferior rectus. So you cannot recess an infra-oblique beyond 12 millimeters. So the peculiarity is in its anatomy, functional appearance, and the response to surgery. The proper technique, there are multiple opinions, multiple ways of doing the surgery, and unpredictable undercorrections. Very rarely you will have a overcorrection in an infra-oblique recession. It is quite forgiving muscle compared to the superior oblique. It is quite forgiving. These are few of the recession techniques which have been suggested. So A is the origin and B is the new insertion. So at Finks, it will give 8 millimeter effect, apt and call. We will see all the videos, and that's why I'm hurrying it up.
You can go to the videos.
Yeah, we can directly. Yeah, how to select, these are again similar things. Pure recession, anterior positioning would affect. So yeah, we will be talking with, can you, I don't have a switch to do it here. Okay, so Finks recession is, so these are all, I follow these things, and they may not be necessarily for everybody, but the basic things are there. Finks recession I would do for a unilateral, very minimal infra-oblique overaction. Normally with a bilateral, very little infra-oblique overaction, we can just skip it or leave it. But with a unilateral, with a V pattern, you can do a Finks recession. Finks recession is essentially 6 millimeter posterior and 6 millimeter inferior to the lateral rectus insertion. Right? It's quite simple. You go 6 millimeter posterior and 6 millimeter inferior to the lateral rectus insertion. This is the, we have hooked the lateral rectus, and then we'll go 6 millimeter posterior and 6 millimeter inferior. That would be the anterior point of infra-oblique insertion, the new insertion. This would effectively give a 8 millimeter effect. If you want to have a 10 millimeter effect, you can go 6 millimeter posterior and 8 millimeter inferior. So, but normally Finks described it like this, and it also had a Finks marker with two arms of 6 millimeter each. So you can just place it like this. It was in a shape of L. So another technique is when we have a moderate overaction, but no hyper or very little hyper in primary position. I normally do a graded recession depending on whether it is +2, +3 infraoblique overaction. If there is not much of a hyper in primary position, we can go for graded recession, which was described by Apt and Call in their article in AJO. So what it does is it recesses, it's more or less a pure recession with no effect on hyper in primary position, very little effect on hypertropia in primary position. So you can do a recession according to the table which has been published by Apt and Call. This is from inferior rectus. This is inferior to inferior rectus and temporal to inferior rectus. Next are two more surgeries where you can have, so this is again we have hooked the infraoblique. So if you have a very large hyper in primary position with a large overaction, you can do a modified iliac and Nankin. So what you do here is you take the you tie the anterior suture right next to the inferior rectus, and the second suture is tied very close to it in the line of inferior rectus. So this is known as bunching of infraoblique, and basically it is to prevent anti-elevation syndrome.
Not bunching. This is to prevent bunching. We are separating it by 5 millimeters.
No,
by the modified iliac 19. You are saying modified iliac 19, huh?
No, I am saying modified iliac 19. I am bunching the muscle.
No, in modified we don't bunch.
Acha.
5 millimeters behind. The real one was bunching it just in front of the inferior.
Just in front of the inferior. So the next is when you don't have a very large infraoblique, when you don't have very large primary position hypertropia, we can do a Parkes recession, which is a recession with some effect in anterior positioning also. So it will pull the globe down and will do the recession. The scheme is very simple. You have to go 3 millimeter posterior and 2 millimeter temporal. There is no gradation in this. This would give an effective 10 millimeter recession and some anterior positioning. That some anterior positioning will take care of the moderate hyper in primary position. So this is, here we have hooked the, is it there? No, I can't do that. So this is also to show how you have to hook the infraoblique. You have to see it and then grab it and then pass a hook underneath it, and then you have to see through the infraoblique, and you can actually see the sclera. If you can see the sclera, then you have hooked the whole muscle. It is very important to hook the whole muscle because infraoblique can have a couple of multiple insertions also. So you hook the muscle under direct visualization, and then you cut it and then tie the sutures, and then the infraoblique is ready to be tied at a new insertion. So for Parkes recession, it will be 3 millimeters posterior to inferior rectus and 2 millimeters temporal. Just show
the video.
Yeah. This I think we took care of the same video. This is the second last slide. So, there is another procedure which is nasal enterization, which was primarily devised for a very large infraoblique overaction and a large hypertropia. And this is basically, it changes the course of the muscle by putting it, see this is the inferior rectus and this has been sutured nasally toward the origin. So basically what it does is, it makes it an intorter and a depressor, and it also does not cause anti-elevation syndrome. In fact, it can be used in cases where anti-elevation syndrome has occurred because of total anterior positioning. So useful in select cases where there is very large, okay. So that was all. Just a small word on anti-elevation syndrome. Just this one slide. So this occurs this is यहाँ change हो गया, वहाँ नहीं change हो रहा. Okay. So this is actually a co-contraction syndrome. It is an adverse outcome of enterization, especially if you do a unilateral enterization. This causes recurrent elevation and adduction. Also, recurrent overaction with hypertropia in side gazes. So axis anti-elevation and attempted elevation and adduction. So what happens is infraoblique becomes a depressor, and so when patient tries to adduct and elevate the globe, both superior rectus and infraoblique contract, and that causes a co-contraction syndrome. This will also cause a reduced palpebral pressure width and a Y pattern. So that's all regarding infraoblique.